Hello everyone, I'm Cynthia Moorhead and I will be talking to you about my Change project based on a bill about improving maternal health. At the end of this presentation, you will be able to understand H.R. 4387, the Maternal Health Quality Act of 2021, which is the legislation that my project Change is based off of. You'll be able to describe the Change project and how it relates to this act and why there's a need to be a change. Identify the key stakeholders who will help in this change and the patient population for whom this change is intended for. State the financial implications of this change. Explain how the change was effective, and explain how the practice change can be sustainable after implementation. So here is my thesis statement that briefly goes through my practice change, which is the implementation of a standardized clinical pathway for nurses, which includes patient education, decision guidelines when caring for perinatal patients in their home, and also establishing and continuing collaboration with perinatal care clinics to improve maternal health care quality and outcomes. So the bipartisan bill was introduced on July 9th, 2021 to reduce the alarming rates of maternal deaths in the United States. It was referred to committees for debate before sending to the whole chamber. It's sponsored by Democrat Representative Robin Kelly. It had 20 co-sponsors, 11 Democrats and 9 Republicans. 12 days later, the Energy and Commerce Committee voted to issue a report to the full chamber recommending that the bill be considered further, which is a good sign as only about 1 in 4 bills are reported out of committee. In January of 2022, the bill is passed by the Senate with some changes and it's sent back to the House. In March 2022, the bill is passed by the House with changes and it goes back to the Senate. And then the next day, the Senate agreed to the changes. On March 15, 2022, the bill is enacted and signed by the President. So here's a summary about the Act, which was placed to amend the Public Health Service Act. It has 2 parts to it. One is to improve maternal health care, and the second part is to improve and modernize maternal and obstetric services in rural areas. Part 1 of the Act is what I'm basing my project change on. So specifically, it requires that the Department of Health and Human Services to undertake activities to improve maternal health by awarding grants for developing practices to improve maternal mortality, and also to train healthcare professionals to reduce and prevent discrimination when providing maternal health services. The Act also provides grants that support perinatal quality collaboratives, which are networks of healthcare and public health professionals who work to improve pregnancy outcomes. So why do I feel this important project change is necessary? So this is important for me because I live in the state of New Jersey, where the maternal mortality rate is one of the highest in the nation. In a recent 3-year study by the Department of Health's New Jersey Maternal Mortality Review Committee, looked at 125 deaths and reported that more than 80% of the top 4 pregnancy-related underlying causes of death were determined to be preventable. The national rate is about 60%. The most common underlying cause of death were due to cardiovascular conditions, hemorrhage, preeclampsia, eclampsia, and embolism. So the data also shows that we continue to have disparities in poor maternal outcomes with Black and Hispanic women compared to white women. So why is change needed? Well, because the preventable maternal mortality is associated with violation of mother's right to life, the right to freedom from discrimination, and the right to safe and quality health care. In the Nurses Code of Ethics, Provision 8, it declares that health is a human right, a universal right, which is a fundamental expectation. Take a look at this interesting infographic compiled by Creer Perry for our national program that looks at the countries that care most about human rights and how they rate in maternal mortality. As you can see, there is a correlation. In addition to Provision 8, nurses are obligated to address disparities, and although it's complicated with the increase of culturally diverse populations, the real emphasis of this provision is on collaboration to meet health needs of individuals, community, and the public to reduce health disparities. So here's my change idea. In our program, we see patients beginning from pregnancy until their child turns 2 years old. Nurses conduct regular nursing assessments, connect patients with appropriate care and resources to manage chronic conditions, and educate patients on prenatal and postpartum warning signs. So these are just a few ways nurse home visitors can be a part of the solution because they play a critical role in prevention. But I think that we can take actions to move towards the ultimate goal of lowering patients' risk of maternal morbidity and mortality. So first, we know that racism is the key driver for disparities, so we must acknowledge implicit bias. As part of my change idea would be to integrate education on implicit bias and racism to provide culturally responsive care. Another part of the change idea is to create a standardized guideline or a clinical pathway for nurse home visitors to use to guide their practice according to medical guidelines, in addition to nursing assessments and nursing patient risk factors. The clinical pathway would include providing education at certain timeframes. Our program has a vast amount of web-based facilitators nurses could use to educate patients, but having them all on one document with hyperlinks to the facilitators would be more efficient. Also, the pathway would include links to other online resources. So, for example, every nurse would share with every patient the 1-minute video, CDC's Hear Her campaign. And lastly, we need to be able to connect with patients' providers to promote continuity of care. Part of the change idea is to reach out to local perinatal healthcare clinics to set up meet and greet meetings during our lunchtime to provide information about our role as nurses in the community and seeing their patients. One of the ideas is for nurses to have access to one point person, a clinic nurse, so that when a nurse home visitor assessments warrants notifying the provider, the nurse can call directly and speak to someone instead of having calls go to voicemail. So who are the stakeholders and how can we acquire their buy-in? First, let's look at whom this change project is intended for. We see first-time mothers ranging from the ages of 13 to 45. 34% are between the ages of 20 and 24 years old. 66% are Hispanic. As per race, 24% are Black, but 24% decline to identify. We have 43% who are Spanish-speaking, and 100% are low income per the federal poverty level, and 60% of have Medicaid at the time of enrollment. So who are our stakeholders? We definitely would need buy-in from perinatal clinic providers. Nurse home visitors can be eyes for the providers because the nurses are in the homes of their patients and they're seen regularly. This could be a two-way street in that if a provider hasn't been able to contact the patient, like missed appointments, the contact person could call the nurse involved in the case. And nurse-family partnership is in every one of the 21 counties of New Jersey. The managers throughout the state meet monthly, and this could be something that would be an easy buy-in, and they could implement it as well since their population is similar to ours. And to create the pathway, we would need a small group of nurses. And once it's created, we would be able to share it with all the programs. And the nurses' buy-in would be to utilize it, which would only benefit their practice and make it easier. So midwives would also be key stakeholders. We can collaborate with birthing centers. Midwives can help to substantially reduce maternal mortality. And in New Jersey, certified nurse midwives and certified midwives are licensed and regulated by the Board of Medical Examiners. We will now look at the Change Project implementation plan. So resources needed to implement the plan would require for implicit bias educational training for nurses, 3-part implicit bias online training through perinatal quality improvement would cost $135 per learner. The training would be done during working hours. So the total cost for 8 nurses would be about $1,080. The creation of the clinical pathway to share and review the pathway with other team members in-house. We would need a group of 4 in the task force, and they would meet monthly 2-hour meetings for 6 months. So total man hours would be 48 hours, and meetings to develop and train other members would be done during work hours. Also, every patient would receive a A1 Save Your Life magnet, and that is $200 for 200 patients. So outreach with the providers, that's the plan. To do that, Lunch for Healthcare Providers meetings, for the collaborative meetings, would cost about $55 for a hoagie platter lunch, and which includes also water, and the total would be about $262 for 4 meetings. And also providing for the printed information related to our program, that would be free, as we receive that from the national program at no cost. Now we'll review the teaching and training that would be provided for the stakeholders. So nurses would receive the implicit bias training and also the training session from the task force to review the clinical pathway so nurses can familiarize themselves with it and utilize it for practice. And for patients, teaching on prenatal and postpartum danger signs, including the CDC's Hear Her campaign video. And all patients would receive a A1 Save Your Life magnet. Let's now review how to determine the effectiveness of the Change Project. So nurses would be able to express an understanding of biases, and they would be able to reflect on their own awareness of their behaviors in certain situations where bias occurs. The clinical pathway in collaboration with healthcare providers, we'd see less frustration with nurses attempting to contact healthcare providers while at patient's home. Successful communication where the nurse is able to call directly to a contact person would be, result in improved access to continuum of care. And patients would verbalize understanding of warning signs and feel confident about expectations, which leads to self-advocacy. Let's look at recommendations for sustainment of the Change Project. So we would require implicit bias training for all our nurses, and the clinical pathway would be maintained and updated by the task force. For example, if a link to a certain teaching document or video is changed, we would change it on the pathway as well. And for collaboration with the healthcare clinics to be sustainable, we would need to continue connection by assigning a nurse who works in the area to that particular clinic. And the nurse would be able to drop off program pamphlets on a regular basis. So key points to remember, my change project is based off of the HR 4387 Maternal Health Quality Improvement Act of 2021, which focuses on maternal health care. New Jersey has one of the highest rates of maternal mortality in the nation, and the most common underlying cause of death is due to cardiovascular conditions. Significant racial and ethnic disparities in maternal morbidity and mortality exist in the United States, where Black women are 3 to 4 times more likely to die of pregnancy-related death as compared with white women. Implicit bias, unconscious bias training is essential to improving the quality of care. And patient education related to prenatal and postpartum danger signs is important for patients to be able to recognize these signs and symptoms and take action to seek medical care. So there should be strong collaboratives set into place to improve patients' continuum of care. These are my references. Thank you for watching.